All right, so this is just, again, we're describing enrollees. In some ways, this is kind of descriptive, right? It's kind of fairly basic, but we'll try to put in some information about how this translates into the data or into analyses and study design and that kind of thing as we go along. So we got, 80 million people enrolled in Medicaid and CHIP in the 50 states and DC in 2024, with millions both in Medicaid and CHIP. And note that those two, I believe those two numbers they add up to the total. But there's, obviously for some of those people, they may be, the enrollment in Medicaid versus CHIP may be a little bit more complicated than just either or. Medicaid program has obviously grown a lot over time, and that's not just because of, say, the Medicaid expansion. It's a giant program with, billions in spending. And so attention to it, of course, is warranted. But it's not like spending has necessarily ballooned while enrollment hasn't, or some of those kinds of things. Those are fairly tracked together. And again, MacPac is one of the great places to go for resources. We listed that on our resources page. There is a link down below. This is just using kind of enrollment information and Census Bureau, or I think from the ACS. And so kind of looking together at percent of U.S. population then that's covered under Medicaid, depending on how you calculate it. People may be listed as enrolled up to 29% of the population, whereas survey data may differ a little bit, and that's people's reporting of their Medicaid enrollment does often differ when you compare it to Medicaid enrollment in say an enrollment file. That does happen. I've also seen some comparisons of, I think, duals in looking at the Medicare Current Beneficiary Survey and the TAF by CMS. I think it was at Academy Health this year, that also kind of looked at that, and there are usually differences, and that could be chalked up to people not being aware that they're enrolled, or a number of other things. Could be depending on how you roll things up at one point in time versus months. So there are going to be potential differences, but somewhere between, you could say maybe somewhere between those teens and all the way up to nearly 30%. As we noted, we've got a number of different potential populations that are kind of covered by Medicaid. We have children, especially children below a certain level of income, parents and birthing parents, those kinds of groups, and then of course we're also talking about duals. People who are in nursing facilities are majority covered, and then quite a few at the very top, quite a few of just lower income adults. So a lot of different populations based on the kind of eligibility categories alone, as they break down some pretty high percentages in some of the groups. In addition, if you want to think about how that may play out across some other populations, so race, ethnicity, for instance, you'll see variation there. Children and adults, depending on income levels, and disability status, are all potentially tied to fairly high rates to Medicaid enrollment. And then of course we got Medicaid expansion enrollment, which has definitely grown. The expansion group itself, in terms of both those that are newly eligible as well as in general, has gone up some, but you can see that there's also the other Medicaid populations also gone up as well. So plenty of change after Medicaid expansion as well. The growth kind of continues. And then just kind of some differences in spending by the different groups. So again, different eligibility. It's important to remember that the Medicaid program is quite a few different, fairly distinct, or at least fairly kind of self-characterized, or unique, or that kind of different groups, that have different needs and different usage patterns and things like that. And so you've got kind of a total, but then we've got children, the Medicaid expansion, adults, other adults that could be parents or birthing parents, or that kind of thing, older adults, people with disabilities. And so the spending really does vary quite a bit by these. And the only thing I would add is that the spending numbers, I mean, that can come across a number of different categories. So that can include, again, inpatient, what we call other therapy file, which is kind of outpatient and everything else, long-term care, pharmacy, the different categories. Those can all contribute potentially to spending. So how would we characterize these beneficiaries? We have an eligibility group code that's a monthly variable, and a lot of times this is, if I could say, where we spend most of our time when we're kind of trying to put things together to check things out a little bit. We spend a lot of time in the monthly variables, but then of course again it comes with a trade-off for how exactly you're going to roll things up. Much of the time, at least, we're looking at an annual level, although there are plenty of times when we have gotten into the monthly. And so it's a time varying variable. And so if you need to roll it up, how you're going to roll it up is a choice you have to make. So with those monthly group codes, it appears 12 times in a calendar year file. But there's also as I mentioned earlier relating to CHIP, a latest indicator. And again, that doesn't capture change, but it's also a single variable. So they're going to be trade-offs in terms of the time you spend and those kinds of things. Lots of different possible values. Some are all states, some are state optional, and so you really need to understand that field pretty well. If you're looking at Beni ID, which is kind of the typical beneficiary ID that might be used as an identifier in a study, it's possible for one person to have more than one observation in the DE file because they may have more than one unique eligibility code in a given month, not just a given year, if they qualify for more than one program. So again, a person could have multiple lines if you're looking at eligibility just because they may be eligible for more than one program, or if they've changed states. So again, how you roll up, how you take all that information and use it without losing too much of the information, but also making it analyzable for yourself, is an open question. It's a methodological question that you'll need to answer. And that's kind of what we mean when we say that if you're going to be constructing measures of eligibility, it's going to require some diligence and a lot of decision making. So you're going to need to do your homework and know what you're choosing. But it's what I talk when I teach my methods students. I define methods as a series of choices that you need to justify, and that's the case at any time. But when you're rolling up or trying to figure out how to roll up information or combine information around Medicaid eligibility, it's definitely there are definitely plenty of potential choices that are going to come up. So that's something to kind of keep in mind in terms of how you're going to define your eligibility groups. And often I would say, if you are doing an analysis on in Medicaid data, and when you're defining your cohort to develop your data request package, defining defining which eligibility groups you're talking about is probably should be pretty high on your list, probably. Just given the way that programs and benefits and other things break down across eligibility groups across states. And the eligibility group code is describing that basis of eligibility. And again, this is an administrative designation. So the one that I typically use is disabled as a category. That is an administrative determination that's been made. And we have some interview data from Medicaid expansion enrollees who have described the process of becoming determined as disabled as, from the qualitative side, they use kind of battle metaphors. Like it was a real fight, it was a real battle, it was a real, those kinds of things, because it's kind of a legal administrative process that can go on. And so it's a process. And so disablement, in some ways, yes, it recognizes a person's need, but it also is a proxy for the fact that the person made it through that administrative process. And so it's how you think about that as a variable, and what it literally represents as an administrative designation is a little different than what it represents as a construct if you're designing, you're studying and thinking about like a conceptual model and how that fits around the particular population you're looking at. And then what's really interesting, of course, is that, so we mentioned there are many, many different eligibility codes. So I'm sorry if that scares you on that left column, but you need to know which codes you're using for what. There are a lot of different potential codes for eligibility code. And sometimes maybe you're going to be combining those with age categories. So you may get children who are in CHIP versus children who are not. And so you might end up with, children who are in quote unquote Medicaid versus in CHIP, or those kinds of categories. And what you mean exactly by CHIP versus Medicaid versus, where do you put combination, where do you put combination kids in combination states and some of those other things, how exactly you determine those. You may need to break down these eligibility group codes a little bit, but if you take those eligibility group codes and look at them by kind of age groups, which does matter, you get some, interesting categories. So there are certain ones where it's primarily about the eligibility. There are certain ones where you are looking at age, and then there are some that are a combination. So like I mentioned, children on CHIP versus children in Medicaid, quote unquote. Adults who are covered as parents versus adults, other adults, maybe expansion adults or other things if they're not disabled and they're covered under Medicaid, depending on eligibility group and so on. So a lot of potential ways that can interact. And again, as with all things that we show you, these are, so this is TAF technical documentation. So this isn't just us doing this, but we're sharing it. But as with all things that we show you, you have to take these codes listed, the values of the eligibility group code that are being used. Don't just take this at face value and use it. And that goes with anything that we show you, an algorithm for determining emergency department visits, or an algorithm for determining chronic conditions, or anything else that you get shown in ResDAC, or I would argue anywhere else. Make sure you understand what you're looking at, and don't necessarily just automatically apply these categories to make sure that they work for you. Make sure that they fit with what you're trying to do in your own study. Put it that way, because we show you things that we've used to problem solve. They are not necessarily things that we've done that we've done a validation paper on or something like that, like I've seen some other approaches use. So just make sure that as you're looking at things like this, it's not just this, like this, make sure that you understand what you're getting. What are all those eligibility group code values? Making sure that you understand that. So, but again, those can end up with some interesting combinations. Some other considerations, we mentioned CHIP a number of times. They can operate M-CHIP, S-CHIP combination. Both you need both the Medicaid and CHIP, variables related to both Medicaid and CHIP to really understand the full kind of CHIP and child populations. So CHIP code and eligibility group code, which I believe those are the monthlies, are needed to separate the groups. You're going to have to probably combine information. And one child may qualify under Medicaid and CHIP within the same year, sometimes within the same month. So as I mentioned, it's an added wrinkle like a lot of these things are. And you're going to have to figure out how to combine that information, how to roll it up into the level of analysis that you're working with, whether it's, persons in a year, within a single year, or some kind of a person month kind of long file, or whatever it happens to be. Birthing parents and newborns, So some state Medicaid programs are going to allow newborns to share a Medicaid identification number with their mother during the first year of life. So how do you separate the services there? How are you going to link that birth parent and baby in the states without a shared identifier? We've done a number of looks at this. I think that we're kind of holding off on putting something out there. I do want to put in a plug for a group that has done a lot of work in Medicaid and in TAF in particular, which is the Medicaid Data Learning Network. And I should put we need to put a link up. I just joined this. It's a kind of a collaborative and group I think there's Academy Health and the Commonwealth Fund are involved. A lot of great researchers working together and sharing resources and things. And I know that they have shared an approach to linking babies and birth parents in TAF, which is not a simple process and not a straightforward one at all. And so I would potentially look at MDLN or the Medicaid Data Learning Network as a possibility. Again, I just want to highlight, always take everything with a grain of salt. Know what you're getting before you take any other person's kind of approach and just apply it. But I would say that's one of the very few that I've seen, because in TAF in particular, linking birth parents and babies, there's no kind of easy link, unless maybe you've got this a Medicaid identification number to link them, but that's only a limited number of states. So I haven't looked at that approach in particular because I'm not a maternal natal perinatal researcher or anything. But I would recommend that as people who have looked at that answer. And I don't want to get too far into that, but I do want to note that is somewhat unique, because just noting that birth parents and babies, that linkage in some ways shouldn't exist like literally on its own doesn't necessarily exist readily in TAF. And so that's not an easy thing. So if you happen to be a researcher, I would look around at definitions and approaches that people have maybe tried to use, but the one that I'm aware of is that one from MDLN. We've looked into it. I've got a couple of approaches we're kind of playing around with, but again, our work is problem-solving work, and it's teaching work, and it's assistance work. It's not going to be some of the validation work and some of the things that I think really are required to really test out approaches like that. But that this is a difficult area overall, and there may be some approaches you can check into, and I'll probably leave it at that.
Need a quick clarification on that, on the parental enrollment in Medicaid. Are parents automatically enrolled in Medicaid if their babies are enrolled?
I don't want to say 100%. I believe that's a state-dependent issue.
Okay, that's what I thought. Thank you.
And of course, again, you've got how does Medicaid operate, but then how does CHIP operate? Because CHIP may cover at least pregnant people. So it also, whether they're enrolled, is that through Medicaid or is it through CHIP, and that kind of thing. So that's just, again, added wrinkle. So duals, level of Medicaid participation is going to vary by dual. So we mentioned, for instance, that SLIMBs, for instance, the Medicaid is only paying Medicare premiums. So you don't want to necessarily expect to find utilization for Medicaid only services, like long-term care, because maybe that person's just getting help with Medicare and that's it. You may see some utilization claims associated with payment of cost sharing on Medicare claims. So again, this may be a case where there's most of the action happening in Medicare, and you're not really going to see a lot of the things in Medicaid that you might think you would see. And again, how that relates to full versus partial Medicaid coverage is complicated. So these are not kind of ready-made categories of identifying people necessarily. Yeah, and so other groups may have only Medicaid utilization, right? So, then of course you got restricted benefits. So some beneficiaries only qualify for limited or restricted benefits. So when you're defining your denominator, make sure that you could reasonably expect to see Medicaid coverage for the service. Some values are going to vary by state. We got that the Medicaid.gov DQ Atlas listed below. We'll be talking a lot about the DQ Atlas later, but that's the Data Quality Atlas. A really good resource that should be on your favorites tab or whatever if you're going to be doing this kind of work. But you got full scope benefits, receiving kind of the mandatory federal benefits and any optionals in the state, comprehensive benefits, and then of course you got the more limited narrow set of services. So in summary, we've got a sizable portion of people receiving Medicaid benefits. It's roughly somewhere around a quarter of U.S. residents covered under Medicaid. I think about a quarter of the births are. Is it a quarter of the births? Yeah. Large number of births in the United States. If you think about long-term care, Medicaid is the big player in terms of how long-term care and long-term services and supports get funded. So there's just a giant program. But knowing who's in the data, it's going to be really important in a lot of ways. Both how you form your cohort and how you define your cohort in making your data request on the front end, as well as how you interpret findings. There are going to be ways where how you interpret findings actually really matters. I'm going to be talking about this a little bit in, I think, segment 4, but how you assume a variable operates, or what you assume a variable even means in your data, you should consider making sure to interpret it within the context of the population or populations that you happen to be studying within Medicaid. Because again, older adults in long-term care are not the same as low-income adults under 65 who are part of the expansion population. They're just not the same population, other than their shared kind of enrollment in Medicaid. And so just keeping in mind that how we build our data on the front end, how we build our analytics sample, the fields that we're pulling from, the variables that we combine to get the information that combine to get the actual kind of analytic item that we want in a particular model. All of those things are should be understood in the context of what eligibility groups you're talking about, what their characteristics are, what their needs are, whether the data are well mapped to their needs versus their utilization, and whether that's going to differ by some of those groups, and so on. Defining eligibility does help us to understand what to expect, right? So in that same way, what can we kind of expect if I'm doing this? And do I see any red flags if I've run a particular analysis and I found something that I didn't expect based on the eligibility groups that I included? So that could be restricted benefits, it could be managed care use, it could be a lot of things. And also expecting state and annual variation. You're going to need to spend time understanding states' policies, waivers, whether things have changed in a particular year, those kinds of things.